Abuse, Neglect, and Chemical Dependency, Module 4. The different types of abuse are physical violence, sexual violence, emotional violence, neglect, and even economic maltreatment. So physical violence would include slapping, punching, hitting. Sexual violence is any form of sexual contact or exposure without consent. And we'll go over the definition of the law on sexual abuse later on in this PowerPoint. Emotional violence is mental anguish that could include threatening, name-calling, things such as that. Neglect would be a failure to provide care for somebody. In the book it does not mention, but some examples of neglect would be physical, developmental, and educational neglect. Also, economic maltreatment is a form of abuse, and that would be like withholding money from someone. Anger and aggression is discussed in chapter 27. Anger is an emotional response to frustration of desires, threat of one's needs, emotional or physical, or a challenge. Anger is not wrong, it is just an emotion. Aggression would be an action or behavior that results in verbal or physical attack. So we can be angry without displaying aggression. So half of all Americans have experienced violence in their families. Also, the secondary effects of violence are anxiety, depression, and suicidal ideation. So for an occurrence of violence to occur, there needs to be a perpetrator, a vulnerable person, whether that be a woman, a child, mentally handicapped person, or someone that is vulnerable, and a crisis situation. If you look on page 534 of your book, it explains what some characteristics of abusive parents are. Usually they have grown up in a violent household or have been victims of abuse themselves, and now they are just repeating the cycle. So some characteristics of these perpetrators are on 533 and 534. They consider their own needs more important. They usually have poor social skills, could have extreme pathological jealousy, like as in a spouse, keeping track of the other spouse, the time that they come home. They may control the family finances, and they are likely to abuse drugs or other alcohol or other drugs. You should read what all the characteristics of a perpetrator is so you can identify those qualities. Vulnerable persons are women, children, elderly especially, or anyone who is at risk of being a victim. It doesn't have to be a woman. The woman could be the abuser and the man could be the vulnerable person. But these are the characteristics usually of vulnerable people. So a crisis situation you can read about in chapter 26 or page 498. So it's not really defined by the experience itself. It's defined by how a person handles a situation. So here are some different ways to describe a crisis situation. It's anything that puts stress on the family with a violent member, or just a struggle for equilibrium in your life and being able to adapt to the situation. It does threaten personality organization. The positive side of it, it does present opportunity for personal growth. We do learn and grow from our difficult situations in life. Crisis is also described as acute and time limited. It's not a long lasting effect. So the different types of crisis situation are maturational, situational, and adventitious. So maturational goes along with Erikson's theory of our different stages of growth and development that we go through, and each stage represents a crisis period. Like when we go from childhood to adolescent, we have to learn different coping strategies than ones that we had before. An interesting part of maturational crisis is, for example, if somebody starts abusing drugs and alcohol, supposedly those persons do not mature appropriately after that period of time. So if someone starts abusing alcohol, like your book says, at 22 years of age, may have the psychosocial and problem-solving skills of a 14-year-old because they have stopped growing psychologically. They have stopped dealing with their issues and have numbed it with drugs or alcohol instead. Now, a situational crisis is from events that are extraordinary and external rather than internal. They're often unanticipated. That would be like a loss or a change of a job, a death of a loved one, change in financial status. You guys are probably in a situational crisis right now going through nursing school. Now, an adventitious crisis is not a part of everyday life, and these are like natural disasters, crimes of violence like rape or spousal or child abuse. Now back to chapter 28. You can look on page 534, the cycle of violence. So Walker described patterns of the cycle of violence as a tension building stage, like incidents such as pushing, shoving, and verbal abuse. So the victim often ignores or accepts the abuse for fear that more severe abuse will follow. And abusers rationalize that their abusive behavior is acceptable or warranted. The tension escalates. Both participants try to reduce it. The abuser may try to reduce it by using drugs or alcohol. And the victim may try to reduce it by minimizing the situation, saying, oh, it's not so bad, or telling others or even themselves that it's my fault, I should have kept the house cleaner, I should have made the children behave, etc. The acute battering stage is when there is the abuser releases built-up tension by brutal beatings. This can result in serious injuries. After that is the honeymoon stage, where both the abuser and the victim are showing kindness and loving behaviors towards each other. The abuser, at least initially, feels remorse and apologetic. They may give the victim presents or make promises like, I will never do this again. And also during this time, the victim usually believes the promises and is feeling needed and loved during this time. And thus the cycle of violence starts all over again with the tension building stage and etc. So that is what the escalation and de-escalation is. You can look at that circle that describes it on page 535. This diagram here explains how some violence occurs when it's not always physical, could be emotional or sexual also. So using intimidation would be one, making somebody afraid by giving them a look or destroying their personal property. Using coercion or threats could be another one. Saying you're going to take the children from the other person, things like that. Using male privilege may be one. Treating a female like they're a servant, making all the decisions, controlling all the money would be another thing. Also, women and men can use sex as a weapon. Withholding sex from their partner is considered abuse. Using the children, like making your partner feel guilty about the children, saying you can't leave because I'm going to take the children from you, or even using the children to relay messages, threatening messages, or things like that. Using isolation, like taking a phone away from somebody or denying them the ability to leave the home or work outside of the home or go to school would be some examples. The effects of violence on children impedes development. Energy needed to accomplish the developmental tasks goes into coping with family violence instead of going through those developmental stages. The effects on adolescents are that they have poorer coping and social skills, a higher incidence of dissociative identity disorders, and poor impulse control, which can lead to anger issues, violence issues, and drug and alcohol abuse also. As nurses, we need to assess ourselves. Some common responses to caring for people in crisis situations or in violent situations, we could feel anger, embarrassment, confusion, fear, anguish, helplessness. We might be discouraged. Some people even have the blame the victim mentality. So we need to really assess ourselves. So interviewing guidelines you can see on page 536. You should not use the words abuse or violence. We need to establish trust and rapport before focusing on the details of the violent experience. Also, you could, on 536, it has some interview guidelines that you can go by. Some ways to question are tell me about what happened to you, and then just listen to what the victim is telling you. For children or elderly persons, you might ask them who takes care of you if you're seeing things like bruises or other evidence of abuse. You can ask them what happens if you do something wrong. How do you resolve disagreements? What do you do for fun? Who helps you with your children or parent? That will help identify also who the abusers might be. Let's say a child is at daycare. You don't want to automatically assume just because a child has bruises on them that it is the parent. It could be a relative or daycare providers. So again, in communication skills for the interview, we want to use open-ended questions. What arrangements do you make when you have to leave your child alone? To identify any neglect that may be happening. How do you discipline your child? Maybe there is some physical discipline that is abusive and they don't realize that it is abuse. When your infant cries for a long time, how do you get him or her to stop? And you could ask them about what triggers any aggression. You could say, what about your child's behavior bothers you the most? And here are more interview guidelines. The don'ts. Don't judge or accuse them. I already said don't use the word abuse or violence. Do not display horror, anger, shock, or disapproval during the interview, and do not ever force anyone to remove their clothing, a child or anyone else that is not willing to. So our assessment needs to include their level of anxiety, how they cope with issues, how the family copes with issues, any support systems they may have, like church or close friends or other family members, any suicide or homicide potential, any drug and alcohol use. It's very important to maintain accurate records. On page 535, of course, many times it won't be apparent, or somebody won't just come right out and tell you they're being abused. On the bottom of 535, it does say all patients should be screened for possible abuse. So some symptoms may be vague, and it can include chronic pain, lack of sleep, hyperventilation, gynecological problems. So pay very close attention to the interview process. The setting is also important for an accurate assessment. You'll want to try to have the person alone, or if they are with a partner or a parent or a child, you would want to assess for any suspicious behaviors. Some of those are listed on page 538. So observe nonverbal responses like hesitation or lack of eye contact. And when you ask specific questions, ask about the time, how, what, where, when, why something has happened. Also, inconsistent explanations serve as a warning that further investigation is necessary, and vague explanations should alert the nurse to possible abuse, like the baby fell from a chair, or the hot water was turned on by mistake, or he was running away and I grabbed him. He fell off his bike. So any bruises on an infant younger than 6 months of age should be considered suspicious. So as a nurse, you are a mandated reporter. So anytime there's any injury, bruising, things of that sort on these infants, it is going to need to be reported. Older children usually do have some bruising on them, and that is typically normal, like on the knees, but if you see it on maybe their back or the back of their legs, something like that, of course, that would be suspicious and could indicate abuse. So some nursing diagnoses that could go along with crisis, violence, abuse could be risk for self-directed violence, risk for other directed violence, risk for injury, anxiety, fear, disabled family coping, powerlessness, caregiver role strain. These are all some examples. So our outcome criteria could be evidence that the victim is no longer hurt or exploited. Maybe some outcome criteria could be family has entered into counseling. Think about what the outcome criteria would be for the abuser. Maybe they have started using aggression in other ways besides physically. So our planning needs to go along with the guidelines of the Joint Commission and the Nursing Network on Violence Against Women, or some examples of some guidelines. Basically, a general tolerance of violence in America needs to change if family violence is going to be stopped. Many people, believe it or not, feel that this is a normal part of family life, or it is normal, or they don't realize that they are being abused. So as a nurse, it is up to me and you to educate the public. So some interventions include mandated reporting of abuse. This would be spousal abuse, abuse of children or elderly, or so each state has specific guidelines for reporting. I do know that in Kansas, nurses are mandated reporters, so are teachers and some other professions like bank managers, lawyers, other professions. So it would be illegal for you to not report these. I do know that in Kansas, clergy members are not mandated reporters. So, like if you go to confess, that priest or preacher or whoever of the church would not legally have to disclose that information. So when I say mandated reporting, I mean reporting it to the police, reporting it to your supervisor, or reporting it to an abuse hotline. So the different ways we prevent abuse would be primary prevention, which is teaching so the abuse does not occur in the first place. Secondary prevention would be early intervention measures in an already occurring abusive situation to minimize the disabling or long-term effects. And tertiary prevention is helping them after the abuse, assisting survivors of violence to achieve safety and well-being. So developing a safety plan is key for victims of abuse. This is listed on 543, and you should read the box 28-6 on page 544. So the plan is for a fast escape when violence occurs or even before it occurs. If there are certain signs that the victim knows may be a potential preceding violence, let's say the person, the abuser calls and says, I will be home in 30 minutes, supper better be on the table. This would be a sign of escalation. So the abused person needs to identify these signs of escalation and decide that that is the time to leave. They need to have, if there's children involved or anybody else, maybe a code word that could signal to everyone that they're going to leave. It needs to include a destination of where they're going to go. Maybe they could have a bag packed already, just to be able to grab and go. Have the hotline referral telephone number of a shelter or a safe house on the person. So as nurses, if we're caring for these people that are in abusive situations, if they have not decided to leave their abuser yet, at least if they have some phone numbers, some ideas of how to develop a safety plan, that will be in the back of their mind for when they do decide that they're going to take action, then they'll at least have a plan. Sexual assault is discussed in Chapter 29. If you look on page 553, sexual assault and sexual violence are basically broad terms. It could mean unwanted sexual advances, sexual harassment, stranger rape, marital rape, date rape, drug-facilitated sexual assault, incest, human sex trafficking, even female genital mutilation is an example of sexual assault. Also, it could be denying emergency contraception or denying measures to prevent sexually transmitted infections, maybe even organized rape during war or conflict, and even sexual homicide, like somebody with HIV having sex with another person would be, unprotected sex would be a sexual homicide. So rape specifically is defined in the context of non-consensual activity, involves any penetration of the vagina or anus with any object or body part, or the oral penetration by a sex organ of another person. So here it says non-consensual activity. So that means any unwanted activity, or if the person is underage, they're not of age to consent. That would be considered rape also. Attempted rape means threats of rape or intention of rape that is not successful. Here is the Kansas statutes on rape. You can read over that if you would like to. So here are some statistics on rapes that have been reported to law enforcement agencies. Usually the victim is white and female and less than 25 years of age. The offender mostly is 70% white, 91% of the time male, usually between the ages of 15 and 29. Actually, 45% of them are between the ages of 15 and 29. most frequently occurs during the weekend and between midnight and 2 a.m. You do not need to memorize these statistics. So profiles of sexual perpetrators, they are 28% of them are 10 to 19 years old, 33% are 20 to 35 years old. Many times they're under the influence of alcohol or drugs. This slide says 82% are acquainted somehow with the victim, but actually your book on page 554 says females know their offenders in almost 70% of all violent crimes committed against them. And males know their offenders 45% of the time. So a question to ask yourself, what kind of characteristics are most likely in a sexual predator? On page 555, it describes what the psychological effects of sexual assault are, and that is the long-term effects usually include depression, suicide, anxiety, fear, difficulties with daily functioning, low self-esteem, sexual dysfunction, and somatic complaints. Also, it explains that victims of incest may experience a negative self-image of themselves, depression, eating disorders, personality disorders, self-destructive behavior, and substance abuse. So rape trauma syndrome is described on the bottom of 557, starting out. This is defined as sustained and maladaptive response to a forced violent sexual penetration against the victim's will and consent. So that word penetration, though, it just basically means there has been a violent sexual act. So the characteristics of this rape trauma syndrome are in box 29.1 on page 558. Could be, so these are the first several weeks, the acute phase. They'll have lifestyle disorganization, somatic symptoms, feelings of shame, guilt, helplessness, low self-esteem, maybe even substance abuse, agitation, mood swings, anxiety, shock, confusion, are all part of the syndrome. The reorganization phase is basically a sexual abuse recovery under the outcomes identification section on 558. So that is the extent of healing of physical and psychological injuries due to the sexual abuse or exploitation. So this is the long term. We've passed the acute phase, but still reactions could be intrusive thoughts of the rape or trauma. Could be increased motor activity, increased emotional lability, which means just increased emotions, crying, just variety of emotions and fears and phobias. So pay special attention to the indicators for improvement. How do we come about our outcomes if they're dealing with this properly? So that is under the outcomes identification also in your book. So some good outcomes would be healing of physical injuries, relief of anger in non-destructive ways, feelings of empowerment and expressions of hope, evidence of comfort in relationships, maybe expressions of the right to have been protected from abuse. They're not blaming themselves, and they're realizing this is not their fault. The assessment is explained on 556, and so we always follow whatever the policies and procedures are of the place of employment, but we want to assess their level of anxiety, how they are coping, their coping mechanisms. So they could have some responses like crying, withdrawing, smoking, abusing alcohol and drugs. They could be talking about the event, which is healthy. They could be extremely agitated, confused, or maybe even laughing or joking. So don't take that as something that maybe it didn't really happen, or maybe they're lying, maybe they just have a unhealthy way of coping with this. A positive response, coping would be them saying things like, at least I'm alive. Not so positive responses would be like, this is my fault. If they're not speaking at all, you can ask questions like, what are you thinking or feeling? Or what can I do to help you in this situation? How have you coped with difficult issues in the past, etc. We need to assess their available support systems and their signs and symptoms of emotional trauma and physical trauma. Again, self-assessment by the nurse. We need to examine ourselves. What are our personal beliefs and feelings about rape? Maybe we've been a victim ourselves and need to analyze how we're going to deal with patients going through the same thing. Prepare to give empathetic and effective care. Also, it would be important to examine your own feelings about abortion if they're planning on having an abortion or not if they do become pregnant. We can't influence their decision by our beliefs. We can just be there and support what they decide. So implementation would include, we want them to return to their previous level of functioning, and they probably will not 100% heal from this, but we want them as near as possible to their prior functioning level. In order for them to become healthy again, they need to fully mourn the incident and go through the grieving process, basically. They need to experience anger, and they need to work through their fears. They may need counseling or other ways to learn coping mechanisms and things like that. So again, our outcome or our evaluation, hopefully the rape survivor will have recovered, and that is evident by being relatively free of signs and symptoms of post-traumatic stress disorder, and their lifestyle is close to what was present before the rape. Now we are at chapter 22, substance-related and addictive disorders. So, dependency prevalence in the USA, 14% of adults have had an alcohol dependence or abuse problem at some point in their lives, and 3% of individuals older than 12 years old need treatment for drug use disorders. Substance use disorder on page 413 is a pathological use of a substance that leads to a disorder of use, intoxication, and often withdrawal of the substance if it's taken away. There are many substances of abuse, including alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, stimulants, tobacco, and even other substances. I guess you could say even electronics are nowadays considered sources of addiction. Some medical issues that go along with substance abuse. For cocaine abusers, this could be extreme weight loss, malnutrition, myocardial infarction, or even stroke. For IV drug users, could be infections or sclerosing of the veins. Intranasal users are more prone to sinusitis and perforated nasal septum. And smoking a substance can cause respiratory problems. So some different theories of addiction. Actually, your book only lists neurobiological factors, psychological factors, and sociocultural factors. So the neurobiological factors are the specific effects on selected neurotransmitters. Specifically, your book talks about dopamine, how normal activities such as eating, nurturing, sexual activity, or basically pleasant feelings cues the brain, and then this releases glutamate, and but when we use psychoactive substances, it can release as much as 10 times the amount of dopamine as usual. So basically this is affecting the pleasure center of the brain, and that leads to dependence on drugs because we need more and more to activate the pleasure center in our brain. Now, the psychological factor theory is basically like chronic stress, trauma, people who've experienced abuse or neglect during childhood, this leads to drug dependency. The sociocultural factors are what we learn from our surroundings. We grow up in a family that is using drugs or alcohol, then we learn to do that as well. So the difference between abusing a substance and dependence, or being dependent or addicted to something, I don't see where this is in your book, but surely it's got to be in here because it's kind of important to know the difference. Abusing a substance, usually there's an inability to fulfill role expectations. People participate in hazardous activities. They may have reoccurring legal or personal problems, and they continue to use despite problems they're having. Dependence relates to tolerance to a drug. Tolerance is on page 416, and basically that means they have to use more and more of the drug to reach the same amount that they have before. Like an example would be a person who rarely drinks. If they have one drink, they might have a buzz, where somebody who has developed a tolerance to drinking maybe would need to have 8 or 10 drinks to get that same reaction or feeling. People that are dependent or addicted also will have withdrawal symptoms if the drug is taken away. Substances are taken in larger amounts for longer periods of time. Dependent or addicted people usually have a desire to cut down, but they cannot. And more time is spent getting or searching or using the substance. Some interview guidelines to help with the assessment would be asking questions like, in the last year, have you ever drank or used drugs more than you meant to? This could be a sign of abuse. Have you felt you wanted or needed to cut down on your drinking or drug use in the last year? This could be a sign of dependence. So, details of the assessment, you need to find out what drugs are being used, what route they're being used, how much, the time of last use, and the usual pattern of use. Do they use daily? Do they use on the weekends, etc. So one thing to think about is, why would a nurse need to know the time of the last use? So the answer to that would be so you can properly assess withdrawal symptoms. Depending on the type of drug used, there's usually a specific time that withdrawal starts to take place. And sometimes, a lot of the times, this could be a medical emergency. Some characteristics of persons with substance abuse or dependency would be denial that they have a problem, depression because of the problem, anxiety issues, dependency to other people or the substance, hopelessness, and low self-esteem. Here's a chart on blood alcohol levels. It's also on page 420 of your book, table 22.4. And basically the signs and symptoms that go along with the different levels. So a 0.05 level, there may be a change in mood, behavior, and impaired judgment. 0.2, it could be staggering, emotional lability. A 0.4 is usually the patient is in a coma. So usually a blood alcohol level will be obtained. Either police will bring them in, or if one needs to be drawn on somebody that's been admitted. This will assess their level of intoxication and their level of tolerance. So as tolerance develops, a discrepancy is seen between the blood alcohol level and expected behavior. So, like, let's say somebody comes in with a 0.4 blood alcohol level, but they're walking around, maybe they're showing signs of change in mood, behavior. So what does this indicate? Usually this will indicate that they have a very high tolerance. Also, read in your book, when should a blood alcohol level be drawn on a patient? What if it is not drawn immediately? I don't know exactly where in your book it talks about this, but there should be a certain limit in time when this is drawn. So alcohol withdrawal is discussed in the table 22.5 on page 421 of your book, versus alcohol withdrawal versus alcohol delirium. So you'll want to review that box there. So withdrawal can begin just a few hours after decreasing alcohol. The signs peak after 24 to 48 hours, and then they rapidly disappear. So some of the signs and symptoms would be like hyperalertness, jerky movements, irritability, easily startled. They could have a tremor or feel like they're shaking inside. To reduce their anxiety, we probably, if they become confused, want to orientate them to time and place, clarify any illusions they might have to reduce their anxiety. Also, we want to look at what kind of medications would be given for alcohol withdrawal. Usually that would be a benzodiazepine, So delirium is a medical emergency. It can result in death. It's a very dangerous situation. Delirium can peak 2 to 3 days after alcohol has stopped, and it can last 2 or 3 days. So the signs and symptoms of that are tachycardia, diaphoresis or sweating, elevated blood pressure, disorientation. They could be having hallucinations, hyperexcitability, or lethargy. They could be having paranoid delusions or agitation, and can even have a fever. So we do want to look at what the interventions are for alcohol withdrawal. I'm looking to see what page that would be on. And I am not finding that, so I will tell you that later on in the voiceover when I find that. So you should be familiar, or should familiarize yourself with the different types of drugs and the common signs that go along with these drugs of abuse. So for stimulants like cocaine, crack, and amphetamines, so that would be like methamphetamines or anything like that. That would be dilation of the pupils. They have big pupils. Dryness of the oral nasal cavity, and excessive motor activity. Maybe you've seen some people talking excessively or acting out excessively. So cocaine and crack is extracted from leaf of coca bush. When it's smoked, it takes effect in 4 to 6 seconds. It reaches the lungs and then the circulatory system. A 5 to 7 minute high follows that, and then a deep depression. So 2 main effects on the body are an anesthetic or anesthesia-like effect and stimulation. So it produces imbalances in neurotransmitters, and like I said before, it could produce up to 10 times the amount of dopamine within the brain. Withdrawal symptoms of this drug include depression, paranoia, lethargy, anxiety, insomnia, nausea, vomiting, sweating, and chills. Some examples of opiates would be like opium, heroin, mepridine, which is Demerol. That's usually a drug used in healthcare centers. Morphine, codeine, methadone, hydromorphone, like Dilaudid, and fentanyl. Evidence of intoxication is constricted pupils, so this would be the opposite of cocaine and amphetamines. Decreased respiration, so that's why we need to monitor respiration so closely in people that we administer opiates to. Drowsiness, slurred speech, and impaired judgment and memory. Withdrawal symptoms could be yawning, inability to sleep, irritability, runny nose, panic, fever, and chills. Marijuana is from a plant, and THC is the active ingredient that produces the high. It is a depressant and also does have some hallucinogenic properties. It's usually smoked, but it can be eaten also. The effects would be euphoria and detachment from reality and relaxation. Other effects could be talkativeness, slowed perception of time, inappropriate hilarity, or even anxiety and paranoia. The long-term effects are lethargy, anhedonia, remember that means a lack of pleasure, difficulty concentrating, and loss of memory. Rave and techno drugs or club drugs would be like ecstasy. Some side effects of these drugs are euphoria, increased energy, increased self-confidence, increased sociability, and feelings of closeness to others. The adverse effects could be hyperthermia. People can actually die of overheating, heart failure, kidney failure, and acute dehydration. Date rape drugs have this label because often they are given to people that are unaware they're being drugged, slipped into drinks, or something like that. Rohypnol and GHB are the primary drugs in this class. This produces disinhibition and relaxation of voluntary muscles. It causes anterograde amnesia. People do not remember what has happened. So that's usually when the rape occurs. So the victim wakes up the next morning, doesn't really know what has happened, but feels as though they have been violated. So, self-assessment by the nurse. You need to examine your own attitudes and feelings about addicts and addiction. This may include examining your own use of family members, or even your friends' use of addictive substances. We need to avoid disapproval or condemnation. We need to be empathetic and supportive of abusers or people with addictions, as it is considered a disease, so we need to be treating it as such. The chemically impaired nurse. Nurses are human, just like everybody else, so they are susceptible to chemical dependency, addiction. Does not discriminate between socioeconomic classes, races, or professions. So if you suspect one of your co-workers are chemically impaired, you should have clear documentation of the dates, times, events, and consequences that have happened, and you need to report the facts to the nurse manager or whoever is up the chain of command from you. The nurse manager will then take the facts to the nurse administration. I would like for you guys to, you won't be tested on this, but as nurses, you should know, the Kansas State Board of Nursing does offer a program for chemically impaired nurses. It's called KNAP, the Kansas Nurse Assistance Program. You can look that up on the KSBN website. If you have a problem with drugs or alcohol, or know someone that does have a problem with drugs or alcohol, you can refer them, or they can self-refer themselves to this program, and it offers them help for their problem, and that will help them avoid losing their license or other repercussions that could happen. Okay, an enabler is, here's just a neat little acronym for if you enable a coworker. You excused or ignored behaviors of your impaired coworker. You never told the supervisor. You accepted responsibility for the coworker's unfinished work because they were impaired. You believed that nurses do not use drugs or alcohol. You like to use drugs or alcohol also. You exonerated a coworker's irresponsible behavior by covering for him or her, or you defended a coworker when suspicious behavior was questioned. But basically, an enabler, you would want to look in your book, is the other person that is not the abuser. Codependence is on page 420, and usually there's a cluster of behaviors that go with the partner of the addicted person. So here on 420 it does say people who are codependent often exhibit over-responsible behavior, doing for others what others could just as well do for themselves. They do have maladaptive thoughts, feelings, behaviors, and attitudes that effectively prevent them from living full and satisfying lives. They say many times these codependent people are sicker than the people that are abusing the drugs or alcohol. They are preoccupied with trying to control the addict's behavior, trying to dump out their alcohol, trying to hide their keys from them, some things like that. So codependent people, there is a program for them, and that is Al-Anon. There's a program AA, which is Alcoholics Anonymous, for alcoholics, and there's a program Narcotics Anonymous for narcotic abusers. Al-Anon is for the friends or family members of the addicts. You can read about Alcoholics Anonymous on page 424. Al-Anon is also mentioned in there, and Alateen for teenage relatives of alcohol abusers. So assessment of the impaired client includes assessing if they have any suicidal or homicidal thoughts or plans, if they are overdosing, we need to give them immediate medical attention. What are their withdrawal symptoms? What is the specific drug they've been using? Any physical complications like tremors or seizures? What's their interest in treating their addiction? Are they in denial? Do they even know they have a problem? And what's the client's and family's knowledge of community resources? Maybe you need to help them to find outpatient counseling or even inpatient treatment. So interventions include, like I said, outpatient or inpatient treatment, maybe just medically helping them through withdrawal symptoms. Sometimes there is a challenge due to the type of addiction or their age, maybe even their physical health. They could be failing medically. Their mental health, their financial situation. Can they go off to an inpatient clinic? Are there any programs nearby? The length of time of the program. Usually they're anywhere from 2 weeks to 30 days in length for inpatient. And family needs. So what if it's a single mother of children? Where are the children going to go during this time? So interventions also include the dual diagnosis principles. Maybe some of these people have other diagnoses going along with their addiction problems. mental health issues like schizophrenia or depression. So maybe they need treatment for those. Also psychotherapy, also relapse prevention. After their initial treatment, they will need help to keep them from relapsing. This could be counseling or self-help groups, not just for the client, but for the family also. There is a lot of healing involved. 12-step programs should be encouraged. Maybe after initial inpatient treatment, they're not ready to go back into their environment, so maybe they need to go to residential programs, or maybe they need to be in an intensive outpatient program. Also, what kind of employee assistance programs do they have? Is their employer going to help them be off for times to go for their treatment? Some medications used for addictions would be like Trexan, naltrexone, which blocks opiate receptors. So when opiates are used, it will not, it blocks it. It also reduces or eliminates alcohol cravings. Camprol is a medication that helps them abstain from alcohol. The mechanism is not well understood. Antabuse is another medication. It causes a reaction, an unpleasant physical effect. They don't feel well if they drink alcohol while they're on this medication. It could induce vomiting and just an ill feeling. So other medications would be like methadone or LAM. I already talked about Trexan or naltrexone that blocks the euphoric effects of opioids. So look up what happens if naltrexone is given. Also, clonidine or Catapres is a non-opioid suppressor of opioid withdrawal symptoms. It may also be given in combination with naltrexone. Okay, so that's the end of this voiceover. I'll be going over any key areas that I feel maybe I have not addressed well enough on Wednesday, and any questions you would have for me you can ask on Wednesday also. The test for this is on Thursday. Hope you guys have a good weekend.